All right, so we've got a patient, and their fever just won't quit. It's
Yeah.
been weeks they've been dealing with this, and all the usual suspects are off the table.
Sounds like a classic case.
It really does.
A fever of unknown origin.
FUO, FUO for short.
That's right. We're going deep today into what causes these medical mysteries and how you, as a general practitioner, can tackle them head on.
It's so fascinating how fever can be such a basic signal in medicine,
Hmm.
but when the cause remains hidden, it becomes incredibly challenging.
Yeah, it's like a smoke detector going off. There's fire somewhere. But finding its exact location can be a real puzzle.
Exactly.
And nowadays, it feels like those puzzle pieces are constantly changing, with new diseases emerging and resistance to our usual treatments, and even the climate seems to be playing a role.
Absolutely. For instance, did you know that in some regions, extrapulmonary tuberculosis is actually the leading cause of FUO, surpassing even malaria?
Wow.
It really highlights how what was once considered rare might not be so uncommon anymore. Okay, so before we get lost in the maze of possibilities, let's make sure we're all on the same page when we say classic FUO. What exactly are we looking for?
We're talking about a fever that's been stubbornly sticking around for at least 3 weeks, hitting 100.9 degrees Fahrenheit or higher, and this is after initial tests have come back negative.
Okay, so the mystery patient walks into your office, fever chart in hand. Where do you even begin to unravel this?
Well, a thorough history is absolutely key.
Of course.
Think of yourself as a detective, piecing together clues.
Right.
Ask about recent travel, any unusual exposures, even family history. You never know what seemingly insignificant detail might hold the key to the diagnosis.
It's amazing how often a patient will mention something just in passing that turns out to be crucial. Like I remember this one case, a patient with persistent fever after a trip to the Caribbean. Turns out they'd been bitten by a stray dog weeks before the fever even started, and it ended up being brucellosis.
Exactly, and don't underestimate the power of a good physical exam. A new heart murmur, a subtle rash, an enlarged spleen. These can all be vital clues.
Speaking of clues, let's talk about those initial lab tests. What should be on your radar?
Start with the basics, complete blood count, inflammatory markers, and blood cultures. Sometimes those common conditions can present in unusual ways, so ruling out those usual suspects is crucial.
Better safe than sorry.
Exactly.
Now let's dive into some of the potential culprits behind FUO, and let's start with the big one, infections.
Ah, yes, infections. They're still a leading cause of FUO, and the specific infections can vary widely depending on where your patient has been. For instance, did you know that in Southeast Asia, infections account for about half of all FUO cases?
Wow, that's a lot.
It is, while in Europe it's closer to 30%.
Interesting. So location really does matter.
It really does, and we can't forget about those sneaky infections like brucellosis, often linked to unpasteurized dairy products, or even those lurking abscesses that can cause a persistent fever without any obvious signs of pain.
So travel history can be a huge red flag. But what about those patients who haven't traveled recently? Could they still be harboring an infection-related FUO?
Absolutely, consider those scenarios where the infection might be hiding in plain sight. A simple UTI, for instance, can sometimes present solely as a fever, or think about endocarditis, where a heart valve infection might be the sole driver of the fever.
So even seemingly straightforward infections can be tricky. It seems like the key is to keep an open mind and consider a broad range of possibilities.
Exactly. And don't be afraid to repeat those initial tests if the clinical picture changes or if the fever persists despite those initial negative results.
All right, so we've tackled infections now. Let's shift gears and talk about those cases where the culprit isn't a bug, but rather inflammation running rampant.
This brings us to the fascinating world of rheumatologic conditions. These autoimmune diseases can cause widespread inflammation throughout the body, and fever is often a prominent symptom.
I imagine these can be particularly challenging to diagnose, given their varied presentations.
Mhm.
What are some of the top contenders in this category that GPs should have on their radar?
Well, for younger patients, adult onset Still's disease is a key player. It typically presents with a trifecta of fever, that characteristic salmon colored rash that comes and goes with the fever and joint pain.
Okay, and for older patients?
Giant cell arteritis is a big one, especially with that classic combination of headache, jaw pain, and tenderness over the temporal artery.
Oh yeah, that one is serious.
It can lead to vision loss if it's not treated promptly, so early recognition is paramount.
Okay, so we've explored infections and inflammatory conditions. Now it's time to address the elephant in the room, cancer.
It's not always the first thing that comes to mind, but malignancies can definitely masquerade as FUO lymphomas, and leukemias are high on the list, so those blood tests and a good lymph node exam are crucial.
And I recall reading that renal cell carcinoma, a type of kidney cancer, can also present with fever as a prominent symptom. That's not something you'd necessarily expect.
You're absolutely right. It highlights how cancer can really mimic other conditions, making the diagnostic journey even more complex.
Okay, so we've covered the big three infections, rheumatologic conditions, and malignancies.
Yeah.
But what about all those other possibilities? Those less common but equally perplexing causes?
Ah, yes, the miscellaneous category. This is where things get really intriguing. We've got everything from sarcoidosis, an inflammatory condition that can mimic a multitude of other diseases, to drug fever, where a medication itself triggers the fever response. And in rare cases, we might even encounter factitious fever, where a patient is intentionally creating the illusion of illness.
It sounds like we could spend an entire episode just unpacking those miscellaneous causes.
We probably could.
But for now, let's focus on the practical steps GPs can take when faced with these FUO cases.
Sounds good.
We've already touched on the importance of a detailed history, a thorough physical exam, and those initial lab tests. But what about targeted testing? How do you choose the right test to pinpoint the culprit?
It's all about connecting the dots. Let's say your patient has localized lymphadenopathy, swollen lymph nodes, and a history of travel to a region where tuberculosis is endemic in that scenario. You'd prioritize tests like chest X-ray sputum cultures and possibly even a biopsy of the affected lymph node.
So you're essentially using the information you've gathered to guide your testing strategy, narrowing down the possibilities based on the most likely culprits.
Precisely. It's like putting together a puzzle one piece at a time. Let's say you have a young adult with a classic Monner-like syndrome, sore throat fatigue, swollen lymph nodes, and of course fever. You'd likely start with a heterophile antibody test to check for Epstein-Barr virus, the usual suspect in mononucleosis.
But what if that heterophile test comes back negative?
That's where the real detective work begins. A negative result doesn't necessarily rule out monomass, especially if it's caused by something other than Epstein-Barr virus. We might need to consider CMV toxoplasmosis or even acute HIV.
So even when a test comes back negative, it's crucial to think critically and not just dismiss the possibility entirely.
Absolutely. And that brings us to the end of part one of our deep dive into fever of unknown origin.
Welcome back to our deep dive into the world of fever of unknown origin. We've explored those common culprits like infections, inflammatory conditions, and malignancies. Now it's time to venture into the realm of the less common, those cases that really make you scratch your head.
You know, sometimes these miscellaneous causes are the most fascinating ones, the ones that force us to think outside the box and really hone our diagnostic skills.
Let's start with sarcoidosis. It's one of those conditions that seems to be a master of disguise, mimicking so many other diseases. What's the key to cracking this particular code?
Well, sarcoidosis is all about those granulomas, those tiny clumps of inflammatory cells that can pop up almost anywhere in the body.
Right.
The lungs are the most common target, but we can also see them in lymph nodes, skin eyes, even the nervous system.
So the symptoms can be incredibly varied, making it even more challenging to diagnose.
Exactly. A patient might present with a persistent cough, shortness of breath fatigue, or simply a nagging fever that just won't quit. And here's the tricky part. Sometimes those granulomas don't cause any noticeable symptoms at all. We might only stumble upon them incidentally on a chest X-ray.
So if you suspect sarcoidosis, what are the next steps? What tests would you order to confirm the diagnosis?
A chest X-ray is a good starting point. We're looking for those telltale granulomas in the lungs, often appearing as enlarged lymph nodes in the chest. Blood tests can also be helpful, especially checking for elevated levels of certain enzymes like ACE, which can be suggestive of sarcoidosis. But to really nail down the diagnosis, we need to go a step further and obtain a biopsy.
And where would you biopsy from?
Well, it depends on where those granulomas are hiding. Sometimes a bronchoscopy to biopsy. The lung tissue is necessary in other cases. A biopsy of an enlarged lymph node or even a skin lesion might be enough to make the diagnosis.
Okay, let's shift gears to another sneaky culprit, drug fever. It seems like this one should be straightforward if a patient starts a new medication and develops a fever. It's probably the drug, right?
You'd think so, wouldn't you? But drug fever is far more complex than it might seem. For one, it can occur with almost any medication, even those over-the-counter remedies, and the timing can be incredibly deceptive. Sometimes the fever doesn't appear right away. It might take days, weeks, or even months after starting a medication for that fever to show up.
That must make it incredibly challenging to connect the dots.
It certainly does. There's no specific test for drug fever. It's often a diagnosis of exclusion, meaning we have to meticulously rule out all those other potential culprits first.
So back to the drawing board with the history.
Right.
The physical exam and those targeted tests.
Precisely, but here's a helpful clue. If we suspect drug fever, we can try a simple experiment, stop the suspected medication if the fever subsides within a few days of stopping the drug. That's a strong indication that the medication was the culprit.
It's a reminder that sometimes the simplest solutions can be the most effective. Now let's delve into one of those rare but intriguing possibilities.
Mhm.
You mentioned earlier, factitious fever. What exactly is going on here?
This is where we venture into the complex realm of psychology. Factitious fever is a type of factitious disorder where a person intentionally acts as if they have a physical illness, in this case a fever, when they don't.
So it's not simply about faking a fever to get out of work or school. There's a deeper psychological component at play here.
Absolutely. These patients aren't simply trying to deceive others. They often have a strong, often unconscious need to be perceived as sick or injured. They might be seeking the comfort and attention that comes with being a patient, or they might have a distorted perception of their own health.
It sounds incredibly challenging to diagnose, especially if the patient is skilled at mimicking real symptoms.
It certainly can be, but there are some red flags that can raise suspicion. For example, the fever might be unusually high or follow an erratic pattern that doesn't make sense clinically, or we might notice discrepancies between the patient's reported symptoms and our objective findings during the physical exam.
For example, they might claim to have chills and sweats, but their skin feels warm and dry to the touch.
Exactly. And sometimes we might even encounter cases where the patient is manipulating their thermometer to artificially create a high temperature reading.
It sounds like a delicate situation requiring a balance of thorough investigation and sensitivity toward the patient's psychological state.
Absolutely. If we suspect factitious fever, it's essential to approach the patient with empathy and understanding. Remember, this is a mental health condition that requires specialized care. Accusing the patient of faking their illness is unlikely to be helpful and could even worsen their psychological distress.
So we've explored a range of potential culprits behind FUO. Those common infections, the inflammatory conditions that can mimic so many other diseases, the ever-present possibility of malignancy, and those intriguing miscellaneous causes that remind us that medicine is never simple. But I imagine there are still many unanswered questions in the world of FUO mysteries that continue to puzzle even the most seasoned clinicians.
You're absolutely right. We've made significant strides in understanding and diagnosing FUO, but there's still much we don't know. For instance, why do some individuals develop FUO when exposed to certain triggers, while others with similar exposures remain perfectly healthy?
Could there be a genetic predisposition at play, making some individuals more susceptible to developing FUO?
That's a fascinating question and one that researchers are actively exploring. And what about the role of the microbiome, that vast community of microorganisms living within our gut? We know that the microbiome plays a crucial role in regulating our immune system. Could an imbalance in the microbiome contribute to the development of FUO?
Seems like every answer we uncover just leads to more questions.
That's the beauty of medicine, isn't it? It's a constant journey of discovery, a perpetual quest to understand the intricacies of the human body and the myriad factors that influence health and disease. And with the rapid pace of scientific advancement, who knows what breakthroughs await us in the years to come?
But that's a topic for another deep dive. For now, let's shift our focus to the future of FUO diagnosis. What emerging technologies and diagnostic tools might revolutionize how we approach these complex cases?
That's a great transition, and that's exactly what we'll delve into in part 3 of our deep dive. Get ready to explore the cutting edge of medicine, where the line between science fiction and reality begins to blur.
Welcome back to the final part of our deep dive into fever of unknown origin. We've explored the common culprits, those tricky miscellaneous causes, and now it's time to gaze into the crystal ball and see what the future holds for FUO diagnosis.
It's an exciting time to be in medicine, especially with the incredible advances we're seeing in molecular
Mhm.
diagnostics. We're moving beyond those traditional cultures and biopsies and entering a new era where we can analyze a patient's entire genome or the genetic makeup of those microbes living within them.
It really is mind-boggling to think about the possibilities.
Yeah.
Let's start with those broad-range molecular tests you mentioned earlier.
Mhm.
How do these work and how might they impact the way we diagnose FUO?
So imagine this. Instead of trying to guess which specific bug might be causing the fever, we can run a single test that checks for hundreds of different microbes simultaneously.
Wow.
These tests look for the genetic fingerprints of bacteria, viruses, fungi, and even parasites all in one go.
So it's like having a universal translator for those microscopic suspects. They could
Exactly.
save so much time and potentially prevent unnecessary antibiotic use.
Exactly. And these tests are particularly helpful when we're dealing with those tricky cases of culture negative infections where traditional methods fail to grow the culprit.
So we're already seeing these broad-range molecular tests making a difference in those challenging cases. What about whole genome sequencing? How might that play a role in the FUO puzzle?
Well, whole genome sequencing allows us to read the entire genetic code of a patient or a microbe. This can reveal subtle mutations or variations that might be driving the disease process, even if we don't know exactly what we're looking for.
So instead of just looking for the presence of a specific microbe, we're analyzing its entire genetic blueprint to understand how it might be behaving differently in this particular patient.
Precisely, and it's not just about infectious causes. Whole genome sequencing can also uncover genetic predispositions to certain inflammatory conditions or even identify those rare genetic syndromes that might be masquerading as FUO.
It really feels like we're on the cusp of a revolution in FUO diagnosis. Are these tests readily available now, or are we still in the early stages of development?
Some of these tests are already being used in clinical practice, particularly for diagnosing those rare or difficult to culture infections. However, widespread adoption is still limited by factors like cost and the need for those specialized laboratories.
But it sounds like it's just a matter of time before these technologies become more accessible. And it's exciting to think about how they might transform the way we approach FUO in the future.
Imagine a world where we can get a rapid and accurate diagnosis in a matter of hours or even minutes rather than weeks or months. That could be a game changer, especially for those patients with serious underlying conditions that require prompt treatment.
It is amazing to think about how far we've come in medicine, and it's truly inspiring to envision those possibilities that lie ahead. But even as we embrace these technological advancements, I think it's crucial to remember that the foundation of good medicine will always be a strong doctor-patient relationship.
I couldn't agree more. No matter how sophisticated our technology becomes, it's that human connection that truly makes a difference in patient care. Taking a detailed history, listening carefully to those patient concerns, and conducting a thorough physical exam, those will always be essential, even in this age of high-tech medicine.
So as we wrap up our deep dive into fever of unknown origin, what's the key takeaway message for our listeners out there, those general practitioners on the front lines of medicine?
Well, FUO is a complex and ever-evolving field, but by staying curious, embracing new knowledge, and combining those cutting-edge tools with those good old-fashioned clinical skills, we can continue to unravel those mysteries of fever and provide the best possible care for our patients.
And who knows, maybe someday FUO will become a term of the past, replaced by a new era of personalized and precise medicine where those fevers are no longer so unknown. Thanks for joining us on this deep dive into the world of fever of unknown origin. Until next time, keep those brains buzzing and those stethoscopes warm.